Hi, this is Brian Kim. I'd like to share with you this interesting case referred to me by an outside ophthalmologist. The patient was a 70-something-year-old lady. She presented with hand motion vision due to a wide cataract, but she also came in on max topical meds, pressure of 46. She was diagnosed with a phacolytic glaucoma. Examination revealed a fixed pupil about 3 millimeters in size and 360 degrees of posterior synechiae and anterior capsular fibrosis. I typically don't use iris hooks or rings to retract small pupils. However, in the case of dense lenses, I always use some type of device to retract the pupil. I prefer stabilization of the iris at the level of the sclera with iris hooks. I feel with rings you can have potential flopping of the device if the iris is unstable. So I'm making my stab incisions for my iris hooks. I'm going to make 4, and then I'm going to put a 5th one subincisionally. I like to place a subincisional hook because when you have unstable and small pupils, that means the iris and or zonules can be unstable. And by placing a hook subincisionally, you're going to have maximal control of that iris and it won't flop into the main incision. So here I'm using a 27 gauge cannula filled with BSS to bluntly dissect the pupil off the anterior capsular edge. And then I go ahead and place my iris hooks one at a time. This is an important point. You want to put your iris hooks in before you fill the eye with viscoelastic. If you fill the eye with viscoelastic first, that pushes the iris back. The pupillary edge will not be at the same level of the limbal plane. And so you're going to just make it much more difficult to place your iris hooks. So without putting anything else in the eye, after you make your stab incisions, just go ahead and put your hooks in like I'm doing here. You want to use the external part of the hook to spin the hook downward and then cinch it on the pupillary edge, and then go ahead and use a stopper to stabilize and retract the pupillary edge. So I'm placing the 3rd hook and then the 4th hook, and I'm going to fill the eye with some trypan blue, and I'm just carefully irrigating the remainder of that trypan blue so that it doesn't go into the vitreous cavity. I'm filling the eye with viscoelastic, and then I'm making my triplanar main corneal incision. I make a vertical groove and then tunnel, and then I stab in to enter the anterior chamber. So when making your subincisional iris hook incision, first you want to make sure you make your main cataract incision before you place the iris hook. If you do it the other way around, it makes it more difficult. So place your main incision first, and then go ahead and make your subincisional stab incision for the iris hook. You want to go through the sclera about a few millimeters posterior to the limbus, and you want to stay parallel. You could actually make a small nick through the conjunctiva first before you make that stab through the sclera. Make sure you're parallel to the iris plane, and make sure you do not puncture or enter through the actual corneal wound. Place the iris hook through the scleral incision, and then go ahead and fixate the iris and retract it with the hook. So this was interesting. I'm playing this in 4x so that you can appreciate that I first went with my Rhexis forceps to try to puncture, and then with the cystotome to try to puncture. Either there was significant anterior capsule fibrosis, or there was just so much elasticity that, or poor zonular support, that I was not able to puncture very well. And so after trying this futilely, I went ahead and placed some more viscoelastic in. So I try one more time to puncture with the cystotome, and after I do this for a few times, I'm able to finally puncture. You can see the cortical milk coming out. So I've decided it is futile to try to make a continuous curvilinear capsulorhexis, and obviously I'm not able to do a can opener capsulorhexis. I'm going to do a scissor-assisted capsulotomy. I'm going to use MST forceps and scissors to cut the anterior capsule, and you can see I'm just doing the best that I can to cut the capsule, and then I'm pulling the capsular material, and you see that it's propagating to some extent, but again, it's not able to really propagate normally. And so I'm making a separate incision, and then I'm going to use the microforceps to cut the capsulotomy edge, fill the antechamber with more viscoelastic, and then approach it from a different angle, again with the microforceps and scissors. I grab an edge of the capsule. I'm having some trouble here, so then I use a scissor to actually lift the flap up, and now I'm able to grab it with the forceps, and then now I'll go ahead and cut the capsule, and then I'll go through the main incision and amputate the rest of the capsule. So now I have a capsulotomy. So I enter first with the INA handpiece to remove all that cortical milk, and to kind of assess exactly what's going on. And this is when I realized that this is truly a Morgagnian cataract. There's no cortex, there's no epinucleus, there's nothing protecting the capsular bag whatsoever. There's this free-floating, dense nugget that's in the capsular bag. And so I went ahead and filled the bag with viscoelastic, and almost like I'm doing an M6 case, I'm actually trying to deliver the lens in a more anterior position and really making sure that the posterior capsule is pushed back. And I enter with the phaco tip, and I'm going to try to break this cataract up and protecting the bag at all cost. And so this is a key whenever you're doing these types of cases. When the posterior capsule is completely exposed, you can't go with high vacuum or aspiration. You're probably going to grab the capsule and rupture the posterior capsule and then have a complication. And so you want to go real gentle. I like to crush the lens, again, doing the mechanical fracturing technique, just crushing the lens in between and then pulsing intermittently with the phaco in order to emulsify the lens pieces. Every time I emulsify the lens, I make sure that the chopper is deep and pushing the posterior capsule back during all these maneuvers. So again, you're alternating between crushing the lens with mechanical forces, and when I'm crushing the lens, I'm not using any aspiration or vacuum in order to maximize safety. I'm trying to mechanically manipulate the lens. Sometimes you do have to use a little aspiration to grab the lens, but most of the time I'm trying to use mechanical fracturing forces to crush and sandwich the lens between the chopper and the phaco tip. And then when I'm ready to emulsify, I'm place the chopper deep in the bag to make sure the posterior capsule doesn't fly up and get ruptured during emulsification. So as you can see, the last piece is emulsified with the chopper deep in the bag. I push viscoelastic in the eye as I pull the phaco tip out. I widen my incisions so that I can accommodate the 3-piece intraocular lens. So now the iris hooks are then removed, the stopper is just pulled back, and the hook is then disengaged from the pupillary edge, and the iris hook is then removed. The INA is used to remove all the remaining viscoelastic material. And so the key part of this case is with a Morgagnian cataract, you want to be very, very careful because your risk for posterior capsular rupture is real high. You want to use mechanical fracturing forces to chop the lens, keep the chopper deep within the bag so that you don't rupture the capsule. And this is an important pearl. When you're dealing with fibrotic anterior capsules and you can't do a continuous curvilinear capsule Rhexis or even a can opener Rhexis, you can do a scissor-assisted capsulotomy, and these don't tend to radialize. So again, when you have anterior capsular fibrosis, when you cut the capsule with the scissors, they don't tend to radialize, so you can do your capsulotomy with confidence. So I'm going to go ahead and hydrate my incisions, and this is the end of the case. I hope this was helpful to you, and thank you for your attention.